Hello friends and colleagues. On behalf of Milton Leong and myself, I would like to announce a new educational service provided by IVF Worldwide. On a weekly basis, we will send out summaries or the conclusions from several lectures that were presented using the IVF Worldwide platform. The correspondence will include a link to the complete lecture should you be interested in viewing them in full. The first mail features a summary from the Ovarian Club meeting on various Luteal support formulations with a synopsis by Klaus Jeding Andersson from Denmark on individualized treatment. We hope that you enjoy and find value in this service. We look forward to receiving any comments you may have. So let us start with the first session.
IMP gives you a higher serum progesterone level, but that's clinically irrelevant when you compare it to oral or vaginal. And the levels do not correlate to pregnancy outcome or endometrial histology directly. Vaginal and IM are not equivalent with regard to the amount of progesterone that reaches the target site in the endometrium, but most of the RCTs, in fact all of them, show no difference in pregnancy rate. And so without a clear clinical benefit to intramuscular progesterone, the reasons to use it are simply cost and less frequent dosing. And so that's the case for IMP. Thank you very much.
When it comes to frozen embryo transfer cycles, the luteal phase clearly needs to be simulated and done so pharmacologically. Clearly, the use of progesterone is mandatory, and while there may be some conflicting data on the outcomes as far as vaginal versus IM, at the very most, if we're going to use an IM form, every 3 days appears to be sufficient, and it's still unclear whether or not IM is truly superior, though the RCTs to date seem to support that. Finally, patient convenience and pain is important to consider, as is cost.
And for me, this is a window to the future. What is the future? Individualize our luteal phase support according to the level of progesterone, which may indeed be the future for managing the luteal phase defect, which apparently is greater, is much profound in the women that they are undergoing frozen embryo transfer cycles.
Final remarks on the oral luteal phase support route with dydrogesterone. We can state that it is safe and as efficient for fresh embryo transfer. The molecule is approved now for luteal phase support in the Netherlands since 2017 and following the Netherlands in more than 60 countries today. It is at low cost, it is well tolerated, and it gives the patient a high comfort. Future research is needed to determine the optimal dose and the efficiency in frozen embryo transfer cycles. And it will be very nice to see whether there would be an additional advantage of the potential immunomodulatory effects of dydrogesterone. What is also important to state today is that the current serum progesterone assays do not pick up dydrogesterone or its active metabolites. So in the context of a personalized luteal phase support, which is gaining more and more ground in our daily clinical practice, it will require the development of an accurate assay to also measure dydrogesterone if you want to individualize the treatment for our patients.
This huge, extensive variation between patients, I think that this very much calls for individualized approaches. And I think that we, during this session, have seen that we can provide exogenous progesterone to eliminate some of the effects that some of the variability seen with the HCG administration, and this may then be one way of compensating these women to secure a sufficiently good progesterone concentration. But which preparation and which individualized approach is, in my opinion, still open for interpretation.